Welcome, everybody. This is our first Community Conversations virtual panel discussion. I'm very happy to be hosting it from Providence, Rhode Island. And I'm delighted to introduce our two speakers today, our two panelists, who are both really terrific. One is Brown alumnus and former president of the World Bank, Dr. Jim Yong Kim. And the other is Dr. Ashish Jha, who is a professor of global health at Harvard, and he will soon become Brown's dean of Brown School of Public Health. So that's exciting. So just a few words about them. We have a lot to talk about, so I'm going to give very brief introductions. Dr. Kim has had a really extraordinary career as a physician and an academic and a public health leader. He co-founded Partners in Health with Paul Farmer. Many people know about that, their work notably on HIV/AIDS, but many other things as well. He later served as director of the HIV/AIDS department of the World Health Organization, served as president of Dartmouth College, and then became the 12th president of the World Bank in 2012. And today he's vice chairman and partner at Global Infrastructure Partners, which is an independent infrastructure investment firm. Dr. Jha is the KT Lee Professor of Global Health at Harvard School of Public Health, where he directs Harvard's Global Health Institute. And he's also a practicing general internist, still sees patients, and a professor of medicine at Harvard Medical School. And as I said, he will soon come to Brown to be a dean of School of Public Health. His research is extensive on a wide range of topics. He focuses on improving the quality and reducing costs of healthcare systems, really looking closely at policy issues, widely published in leading journals, but also leading public voice on a range of healthcare issues, and most notably recently epidemics. So, and I would add that both Ashish and Jim have been involved in epidemics over the course of their careers. They were both involved in Ebola and some other things. So I can't think of two better experts to talk to about the COVID-19 pandemic and the effect it's having on people in the US and around the world. So what I thought I would do is just start by asking Ashish Jha if he could just take a few minutes and just give us a status report. Where are we with the coronavirus outbreak in the US? Are we on a good trajectory, a bad trajectory? What's your general assessment of the current situation?
Chris, thank you so much for having me here. And I'm excited to join in this discussion with my friend Jim, and also as a kind of foreshadowing of my excitement about joining the Brown community and being part of what I think will be very important work on global public health. Before I took on this job, I thought global public health was going to be very, very important for the next decade. The COVID-19 outbreak, the pandemic, has reminded us just how important pandemics are and how important public health is for the world. So I think it's an important opportunity and an important time. What I'm going to do is just take about 5 minutes and give a quick overview of where we are. So we are about 4.5 months into this pandemic. We think the infection began somewhere around early to mid-November in Wuhan in China. And the world really became aware of this disease outbreak at the end of December, early January, when China informed the World Health Organization about this outbreak. And the story from there unfolds in several ways. One is a scientific story, and that story is just remarkable. Within a couple of weeks, the virus had been identified, had been sequenced. Within a week or so after that, we had a diagnostic test the WHO developed in partnership with others, and that test became widely available. And essentially by the end of January, most countries in the world, if they wanted it, could develop a test using the WHO approach. Obviously, the pandemic began with China at the focus, and was quite destructive, not just in Wuhan, but spread to other parts of China. They used a variety of measures, primarily around social distancing, really dramatically lowering kind of activity of people in the Hubei province and in other places, and then also using extensive testing and isolation to bring the disease under control. From there, it went to East Asia, and that's where we saw it next, in Singapore, Hong Kong, Taiwan, South Korea, Japan. And those countries have taken a very specific set of approaches that I think we can come back to talking about. The epicenter of the disease moved next to Europe, mostly Western Europe. Italy really was the first, but from Italy, we've seen other countries, Spain, France, Germany, UK, all of those countries take slightly different approaches, but all of them struggle much more than I would argue the East Asian countries did. And at this point in the outbreak, it's pretty clear that the epicenter of the disease, in my mind, is the United States. Yesterday afternoon, America became sort of the #1 country in the world in terms of number of cases, and is now approaching close to 100,000 cases as of about half an hour ago. It's in the like 95, 97,000, and rising very quickly. And there are a series of reasons why the outbreak has been so devastating in the US, and I think we can agree that we're still in the early days, that the number of cases is going to rise exponentially in the days and weeks ahead. And one of the major reasons we have fallen so far behind on this is really a 2-month lag in preparation and a 2-month delay in getting our testing infrastructure up and running. Testing is starting to get better in the US. If we were having this conversation a week ago, I would have said the testing capacity of the United States is abysmal. Today, I would say it's just mediocre. It's not where it needs to be, but it's better. Yesterday, we tested about 100,000 people across the country. We need to be doing a lot more than that, but it is getting better. And the epicenter of the disease right now is New York and New Jersey, with pockets in California and Washington. But if you look at the data, it's very clear that in the next week to 10 days, New Orleans, Atlanta, parts of Florida, maybe Arizona, other places are going to be hit very hard. This is truly a national outbreak. And a sense that we have taken a variety of measures. They've been half-hearted in some ways. Social distancing has been in effect in many states, but other states have taken it less seriously. And testing is also quite uneven. So I think America finds itself in a challenging place. And I think what happens over the next couple of weeks is going to have a very profound effect on where this disease outbreak goes. Because of lack of national coordinated leadership, it's really a state-by-state effort. And that presents both opportunities, but also a whole set of challenges. And I would be remiss if I didn't just at least mention that one of the major challenges in front of us is getting the hospitals and the healthcare system ready. And there are an enormous set of challenges, from personal protective equipment to ventilators to other things that we have to get going. Look, I think we all wish that there had been stronger and more effective federal leadership. That has not quite been where it needs to be. But we have seen some great leadership by cities and states. Whether that's going to be enough to get America through this is harder to say. But we are at a point where I think we all have a tremendous opportunity to make a difference by engaging our local and state leaders and doing a lot of the things that we know that we need to be doing. So let me stop there and then maybe hand it over to Jim, or go wherever you want, Chris.
Well, let me, I think that's a just great baseline. And you said so many things that I hope we can go into in more detail. But, I think the biggest question on most people's minds is, how is this going to end? And I thought it would be useful to talk a little bit more in detail about how China and South Korea, maybe some other countries, have managed to turn the curve, and whether there's some lessons that we can take back to the US from that. And I know, Jim, you've been thinking about that a lot.
Yeah, Chris, thank you. It's great to be on with you and Ashish. So we've been going crazy with this at Partners in Health, the organization that I started back in 1987, because we're thinking about, well, what are we going to do in places like Haiti, Liberia, Sierra Leone, where no matter what we do, we're never going to have the kind of PCR, the polymerase chain reaction kind of more difficult testing that is at the core of what's going on in China and in Korea. So that's where we started. But then we started trying to figure out, well, so what's going on in the United States? And I was just confused at the kind of language that people were using. There were so many experts, so-called experts, who were saying, it's too late to do extensive testing and contact tracing. You just can't do it at this stage of the pandemic. And if that's your conclusion, then what you're doing is basically waiting for what they call herd immunity. And this is sort of what people had been saying. Well, you know, there's not much we can do. It's just too big of a task. What we really need to do is just kind of wait it out, do the best we can with the social distancing, and eventually all these people will get immunity through just being exposed. Well, the thing is, I've been trying to say this as loudly as I can. If we are going to settle for herd immunity, the path to herd immunity is going to go through an absolutely horrific amount of herd culling. 20% of people who are positive end up going to the hospital. 5% are seriously ill. So we're talking about a kind of carnage that I don't think would be acceptable to anyone. But I think what people have been saying in the United States is, well, the stuff that's happening in Asia, we just can't do it in the United States. And so what I'm working on right now is trying to get at least one state to tackle the virus in the way that's been successful in Asia. Now, it's because it's later, it's going to be more difficult. The scale has to be much larger, but we still have to do it. And I just wanted to show you, I think one of the most important slides in this epidemic, which has come out of China. Excuse me. All right. So this is the data from Wuhan. So when the epidemic started, the R is essentially the replication rate. How many new cases result from a single case? And in the beginning, it was very high, 3.88, almost 4 new cases per each individual case that they discovered. And this is very high. You know, for the common flu, the replication rate is in the 1.3 to 1.5 range. So this is very high. And then with the application of very strict social distancing measures, including no cars on the street, they got that rate down to about 1.25. But it didn't go down below 1. We have to get it below 1 to stop the epidemic. It didn't go below 1 until they did 2 things. In the first few weeks, up until about January 20th or 25th, the Chinese recognized that they had to stop anyone from going out in public and infecting others. But then the rate of rise was from intrafamilial cases. So 70 to 80% of their cases now were coming from family members who were infected by people in their own family, often in their own household. And so they knew that they needed to do more than that. So what China implemented was what they called central quarantining. And this is university dorm rooms, hotels, where they would bring the people who were infected and their close contacts and offer them not only medical care, but food and all the other things that they would need. So it was a supportive environment. Now it was done mandatorily. So it would be very difficult to do something like that in the United States. But Korea did essentially the same thing, but that was not mandatory. It was much more a sense of, don't you want to protect your family? If so, we have these facilities available, and the uptake was very high. The other thing they did, which is so critical, is they did very aggressive testing with contact tracing. Now, this is 100 years old. What we've, let me get out of this slide. The contact tracing is something that we discovered in the beginnings of the history. By going through and finding out where the disease was, where it started, the great John Snow, who was one of the early figures in public health, discovered that cholera was coming from one specific water pump in London. And so the intervention that stopped it was to remove the handle from that water pump. Now, in this case, this is such a tricky bug. And in my conversation with the Korean CDC, they gave a sense of it almost as if it was a person that they'd gotten to know. And they said, this thing is very hardy. This thing is very sneaky. We have to go after it as aggressively as we possibly can. And that will mean much broader testing with contact tracing. There's been some difference of opinion. And again, many very respected public health people have saying we can't do this. But let me put it this way. There's no way for us to stop the economic restrictions. There's no way for us to stop the social distancing rules until we have the ability to do the kind of testing and contact tracing that will give us confidence in loosening up some of those rules. Korea, people are are still, engaged in businesses. They're walking around because they actually know exactly where everyone is who's positive. The minute someone gets symptoms, someone goes, they get tested immediately. All their contacts get tested. They get separated. They're provided services. And then the contact tracing goes so broadly that the Koreans end up being fairly confident that they caught this particular outbreak. Now, we have to do that or we can't remove the restrictions. And so you hear a lot of flattening the curve. You can flatten the curve, but that means it's going to go for a very long time until you take this other approach. So flattening the curve means taking it from 3.88 to 1.25. But in order to stop it, you've really got to put those other measures. So how long was it going to take? Well, in Wuhan, after they put the much more stringent measures in place, after they started doing central quarantining and testing and contact tracing, it took more or less 2 months. So that's where we need to get to. We have done this at Partners in Health in some of the poorest settings in the world. So when you say something like, well, can you quickly train thousands of contact tracers, people who will be part of the link to the public health system, and get them to read through a script and contact the people that need to be contacted. From my perspective of having done this in Haiti and Liberia and the slums of Lima, Peru, I think, wow, everyone can read and write. Everyone has the smartphone. We can do this. And I think one of the most important parts of it is that I think we can get the sense, build the sense among the people in the United States that we're not sitting back waiting for the virus to do to us what it will, but that we're actually out fighting the virus. That's how the Koreans talk about it. We're out fighting the virus every single day.
Mm-hmm. So let me ask you a question, because this is, one difference. There are many differences between the U.S. and South Korea and China. But one is that for some reason, and Jim or Ashish, you probably know the history, we have sort of these state-run public health agencies that are only not very well linked together. And, you look at a pandemic like this, and New Jersey is linked to New York, is linked to Connecticut, is linked to Rhode Island, is linked to Massachusetts. So can we, and I think we do have state leaders who are stepping up, but I guess my question is, until we really have federally driven, consistent policies and practices, are we going to be able to make a difference?
Ashish, go ahead.
That's a question to either of you.
Let me start. I think it's going to be much, much harder. Obviously, federalism has a few advantages that this has shown. When there has been a complete lack of federal leadership, we have seen states step up, and that's great. But that only goes so far. And at some point, each state doing it themselves just doesn't work. A lot of states don't have the expertise. And it turns out people cross state borders. I mean, so often, and the virus crosses state borders. So the interesting history of public health at the state level has always been that while each state has its own public health agency and they run it, there's always been very close coordination with CDC. There are CDC officials who sit in state health departments, and the states have always looked to CDC for expertise and guidance. And in this outbreak, CDC has, to just be very frank, has been sidelined, has had a much smaller role, which is amazing because CDC is a fabulous public health agency and should be absolutely taking the lead in helping states. It's not happening. And so I think without federal leadership, we're going to see kind of halting, sporadic progress. But we're not going to be able to kind of deal with this at a national level. That where the only thing that will work is CDC and federal leadership out of the White House, not just even out of HHS.
I don't know, Jim. Do you have any thoughts on that?
Yeah. I think in the last a month or so, I've been just calling everybody. I've talked several times with Tony Fauci, who is now sort of ubiquitous and such a wonderful man. I started working with Tony almost 25 years ago on tuberculosis and HIV related issues. And I think that in poking at sort of every place I could poke to see if we could help, or if there's something that we could bring to the table, I came to the conclusion that I think at this point, because exactly what Ashish said, the great hope is that the governors, or that some consortium of governors, can take the lead. I think that if we can in one place, and again, we're trying to put a system like this together in one state, in the case of Partners in Health, what we're trying to bring is the sense that you can do this with a community health worker type program. I think if you set it up in one place and several things happen. One, people feel like that they can get tested if they want. People hear stories about someone testing positive, and then all of a sudden, a group of people jumps in, finds out all the people who they've been around, the people who have close contacts get tested, the testing circles grow, and we begin to feel like we're on offense against the virus. I think if it happens in one state, it's hard to imagine that other states are not going to want this as well. And so what we're hoping is if we can get up and running in one state, that a consortium of governors, but also just citizens who are scared to death, sitting in their homes, in New York, they've done a great job of increasing testing, but the rule still is you can't get tested unless you're sick and in the hospital. And from a public health perspective, that's frankly malpractice. And I don't want anyone to get the idea that this is the right way to do it. It's not. It's absolutely the wrong way to do it. Sometimes we have to implement policies like that in Africa because we have no option. But it's crazy that that's happening here in the United States. And so if we get rid of the malpractice and actually do what we're supposed to do from a public health perspective, our hope is that this will spread and spread quickly.
So what is it? What's going on with testing? Because I still hear reports in Rhode Island. There was a shortage of swabs. There are still shortages, maybe worse in some areas of the country than others. But is this just hard to do? Does it just take time? What's the holdup?
So I'll start, and Jim, you may have thoughts on this as well. It's been a bit baffling why this has been as hard as it has been. Again, the history here is, WHO put out its test kit more than 2 months ago. We decided not to use that and go our own way. Not necessarily unreasonable. CDC has a long history of being able to build its own tests. And then it was sort of one failure after another after another. And I think all of us, most people sort of agree that it was ultimately a failure of federal leadership to prioritize solving these issues. And then the sort of the last big holdup was, 3-4 weeks ago, the vice president stood up and said, we have 1 million test kits are about to go out. And that actually, a lot of private sector organizations, a lot of labs said, oh, okay, well, 1 million test kits are coming. We don't have to really build it ourselves. And it was really only about 3 weeks ago, 2.5, 3 weeks ago, that people realized there were no test kits coming from Washington or from Atlanta, that we really needed to do a community by community, local build up. And so you started having people, hospitals, universities, others starting to build their own test kits, private companies. And then you've run into all the standard roadblocks. Like all of a sudden you need swabs, you need reagents. In some places the holdup is swabs, in other places reagents. At some places that the private sector companies just having a hard time getting going. And we've had very little federal coordination. I am optimistic that we're heading in the right direction. Each day I see another extra 10 or 20,000 tests. As I said, we did 100,000 yesterday. That's good, not where we need to be, but much better. My hope is in the next week to 10 days, we're going to be in much better shape. But my goodness, this has taken a long time to get here.
It feels like it. I mean, I imagine that I want to have one of the testing capacity in my university health center so we can, rapidly figure out whether people are sick or not. That
Exactly.
seems like, yeah, make a lot of sense. So the other thing that I'm hearing a lot from doctors, physicians, is just the lack of supplies in the hospitals. And I don't know whether either of you can talk about what's going on with our healthcare providers, but it's just heartrending to hear reports of doctors and nurses and other people who are in the hospitals getting ill because they don't have the protective gear that they need.
Let me start this, and Jim, I don't know if you have thoughts on, Megan Rainey, who's a professor at Brown, she and I just have a piece this week in the New England Journal about this, where we lay out what the challenges are. And here too, it's essentially a lack of planning. Look, we don't generally keep tons of extra personal protective equipment around. Of course, we all knew this pandemic was coming for 2 months, and there wasn't much federal engagement in ramping up production. That has started happening in the last couple of weeks. But what has also happened is because when people realized this was going to be a shortage, there was a lot of hoarding and providers, patients started grabbing masks, grabbing gloves, taking it home, and that has actually created more of a shortage. Mm-hmm. So the solution out of this is really, there are two solutions here. One is we've got to substantially ramp up production. We just have to make a lot more. One part of the issue is that a lot of our masks were made in China, and that production really stopped and exporting stopped during the outbreak. But the second part is that we've got to do a much better job on coordinating, because the disease outbreak is not happening at the same pace across the country. And so if we can figure out a coordinating and sharing mechanism where New York gets all of the equipment now, but that Louisiana gets it 2 weeks from now when they're hard hit, and that will require federal leadership, but if we could do that, we can get through this between that and production and sharing. But right now, every state and every hospital system is essentially competing with each other. They're all going to suppliers and trying to outbid each other for production. And that is not how we deal with a pandemic.
Mm-hmm. Jim, I don't know whether you want to weigh in on that, or I have something else we can talk about. But
Sure. Just one quick thing. Ashish said it, a lot of it comes from China. So China is the country that has the capacity to make these things. So China makes about 50% of all the PPE in the world. Right now, they're making 150 million masks each day. But the demand in China just about takes all of it. Now, what you could do is, I was very glad to hear that President Trump and President Xi had a conversation, because the capacity is there. Now, could the United States reach the kind of capacity that we'll need? Well, we've already surpassed the number of cases that China has had. We're now the largest number in the world. And so how many will we need? It's hard to even get your head around just how many we'll need. And so it seems to me that at some point, we're gonna have to find a way to have a relationship with the places that can make them at the highest volume, and figure out a way to make it a win-win situation. If the U.S. economy goes in a direction that's going to be as serious as some people are saying, if this continues to go for as long as I think it's going to go, it is in everybody's interest to help the United States get its epidemic under control. Just as she said, this is now the epicenter. And so it's in everybody's interest to try to help us get things done. And if we can find products, drugs, China and Korea both are making these immunoassays that give you results in 10 to 15 minutes.
Right.
That could play a very, very important role. It's just time for that coordination, certainly at the national level, as Ashish said, but also on the global level. It's time for it to start, and it's time for it to get very, very serious. In the meantime, all of us have to try to get clear on what's going to be required to have a full response, and then try to get it going state by state. That's the best hope we have, I think, for now.
So Jim, just to come back to, we're focusing on New York and the U.S. right now. That's the epicenter, and some really low-income countries in the world have been a little bit slower for this to pick up, but maybe that's just because they don't have testing capacity. What are you hearing from countries in Africa, and what's it going to look like there?
Well, it's quite varied. And so, for example, in Rwanda, I've worked in Rwanda for 15 years, and they're about as well organized a country, as I've ever seen. President Kagame is extremely evidence-driven on everything. And so right now, we have a better contact tracing system in Rwanda than exists in any U.S. state. And I think Rwanda has a shot at limiting it. Other countries are less well organized. And so when you look at anything, there was some suggestion that you could go county by county and say in the United States, these counties can go in wherever they want, these counties cannot. So much of what we know about the virus is based on the inability to test rather than a real sense of what's going on in these countries. So unfortunately, in much of the developing world, because testing has still been so limited, we don't really know what's going on. But one thing that we seem to have learned, if there are people who are saying, when the weather warms up, this will all go away, we're getting community spread that seems to be proceeding very aggressively in some very warm places. So I don't think we can rely on that, and that's one of the things we've learned.
Right.
Can I add one thing to that, Chris?
Yeah, sure.
Just very quickly. So there are a couple of things that came out of the Ebola response when Ebola hit West Africa 2013 to 2015. One of the most promising to me is the African CDC. And the leadership of this African CDC, and Jim was, and the bank was very involved in lots of very helpful ways in pushing that forward. I think that has really become a bit of a game changer. And Jim, I'm curious if you think I'm overstating its importance, but I have been heartened by its ability to get testing together across for countries, how well it's working. I don't want to overstate it. It's not going to solve all the problems, but I think the African CDC is a real asset that's going to make this a better response across the continent than what we had in the past. Do you agree with that, Jim?
Yeah, I do. Ashish, I do. I think the African CDC did a great job. And if you look at the early response to the first case in Nigeria, they did a great job. They did aggressive contact tracing, and they did limit the outbreak, starting from that first case.
Yeah.
And Nigeria did the same thing during Ebola. I mean, Nigeria had 19 cases, and they spent $19 million, $1 million per case, but they did the most exhaustive contact tracing of anyone in Africa up to that point. And in talking with Bernard Schwartlander, who's the number 2 at the World Health Organization, he said that the Nigerian Minister of Health went with them on the visit to Wuhan, saw what they were doing, and was able to implement it. So I think it's really it's possible. But again, the testing is going to be the key. And I just received a photo because I connected our the Partners in Health project sites with several Chinese manufacturers of these immunoassays. And so before immunoassays are being used in the United States, I just saw pictures of IgM, IgG antibody tests in Haiti being used right now. So if we can leap forward and get those immunoassays, these rapid tests, out into Africa, Latin America, South and Southeast Asia, we may be able to get in front of it.
Yeah.
Good. Let's turn to the economy a little bit. And, it's looking pretty dismal. The U.S. is now facing unemployment levels rivaling the Great Depression, 3 million unemployment claims. Ashish, you had a great tweet that I saw, which I love this quote: "A wrecked economy has horrible health effects. A public health disaster has horrible economic effects. The trade-offs aren't between health and economy, it's how to do both." So when you put out a tweet like that, somebody has to ask you, so how do you do both?
Right. So this has become the debate that I find incredibly frustrating. And people are saying we have to open up because we just can't deal with a wrecked economy. Of course we can't. If we can't do an 18-month shutdown, it would destroy the economy. It would destroy the fabric of our society. We have to find a middle path. And actually, Jim laid out that middle path.
Yeah.
And I have to tell you, I spoke to Jim yesterday, and it was so heartening because so many of my public health friends have sort of said, we'll just have to kind of give up on this. And I'm like, no, we're not giving up. Because the path that Jim laid out is going to be hard. It's going to cost hundreds of millions, maybe billions of dollars. But it's trivial compared to a $2 trillion stimulus that we passed and the economic effect of not doing this. So there is a path out that allows us to open up our economy. Maybe it doesn't let us go back completely to normal, but 80 or 90% back. Allows us to have a healthcare system that's not overwhelmed and allows us not to have large numbers of people dying. It's the path that Jim laid out. It's going to be very hard, but it is within our capacity to do, and certainly no harder than other things. So that's the middle ground, is a little economic suffering, a little human suffering, but we get through this until we have a vaccine.
Krista,
go ahead, Jim.
The frustrating thing for me is that if you look at these stimulus packages, fiscal stimulus and I think I'm talking to an economist now, and I'm only a hack economist, as you know, Chris. But if you look at the tools that are being brought out in terms of both fiscal stimulus and the loosening of monetary policy, the bond buying programs, the thought that comes to my mind is, well, then why can't we get at least as serious around public health measures? And we hear talk of bazookas and the nuclear option. Well, if we're using bazookas on the fiscal and monetary front, we're using squirt guns on the public health front. Yeah. We've given up. I mean, so we've got to now match what we're saying from the public health community with the kinds of outcomes that the people who are trying to get economies back up and running, the kinds of outcomes they're looking for. They're asking very hard questions about when can we get back to work. And it's very simple. Once you get these systems in place, if we're lucky, in about 2 months, we may be able to get back to work. But if you don't put these things together, all bets are off. We probably have to wait for a vaccine. Now, I have to tell you, I hope there's a vaccine in 12 to 18 months, but I don't know if there will be. Yeah. And if there isn't, then we're just going to have public health become a much more central sort of, not only sort of concern, but there have to be a lot of new people working in public health that can help us get there.
Yeah. I mean, basically what you're saying is the best economic policy right now is public health policy, right?
Absolutely. This is not an economic crisis. Chris, the global financial crisis was an economic crisis, and there were things that you could do with both fiscal and monetary policy to restore confidence, all kinds of things we do, cleaning up the mortgage-based asset issue. There were many things we could do. But because this is fundamentally a public health problem, we need to put, and I wouldn't say hundreds of millions or billions, we need to put hundreds of billions. We need to put whatever it takes to solve the public health problem, or we're never going to get the economies back up and running.
Yeah. So let's turn to higher education a little bit. Both of you have been involved with universities throughout your lives. Jim, I neglected to say when I introduced you that you're a fellow of the Brown Corporation and a senior fellow at the Watson Institute, Ashish as well. And, what do you forecast? I mean, we're looking at this saying, hey, we need to open up our schools in September. We need our students back on campus, but social distancing in dormitories is not the easiest thing in the world to do. So what would your thoughts or advice be on that?
Ashish?
Do you want me to go first?
I always let the deans talk first.
Not a dean yet, my friend, not a dean yet. No, look, I think we are, a lot of this is going to be driven by the facts on the ground at that time. I think that there is good reason to believe that we can get this disease under control. We can have the kind of trace isolation, contact tracing stuff that Jim has laid out. And if we are doing that across not just the New England states, but I think across the country by then, there is no reason to think we can't open up classes. There may be certain types of events that we may not be able to do. We may not be able to do certain sporting events that bring 20,000 people together in a single stadium or a single arena. Those will be more challenging. But it is not clear to me that we couldn't bring back the students to school. I just think we have to look at both the disease prevalence at the time, the spread at the time, and our ability to test and isolate at the time.
Right.
So I am hopeful, but I think it will be really driven by the kind of facts on the ground at the time.
Yeah, I think life as we know it has already changed. I think the ways in which we get together. I mean, if you're watching movies or television and you see the way that people touch each other, it's like, oh my God, how are they doing that? So things will change. Now, I think one of the things that will happen, and I think this is good news for both Brown and Ashish, I think public health is going to be more important as part of the overall discussion about how we organize our lives. We've been saying for years that public health expenditures are about 1% of all health-related expenditures, and medical intervention is 99%. I hope this will change. I mean, I hope that many, many more students will want to go and enroll at the Brown University School of Public Health, because these are going to be the most essential functions. I think it's now very clear to people in the financial world how important these public health issues are. Getting back to school, again, I think it's fairly straightforward. The evidence is overwhelming. If you do these, basically 4 things, you've got to do the social distancing, right? And the way we're thinking about it now is test, trace, isolate, and support, and treat. Just these 4 things. If you do all those 4 things, then you can begin to see a world where we have to be careful. I think the patterns are going to be different. I think large events, I think, people shaking hands and touching their faces, I think all of that's going to change. But at that point, I think we can get things going. And in China, I just saw a report about the various parts of Chinese industries that are back up and running. And some of them are, at 30 or 40%, but others 70, 80%. China is getting back on track. Now, they're absolutely paranoid about where the next outbreak is going to come, but now they have this public health infrastructure that's going to jump on these things quickly. Phone calls within 2 hours, contact tracing, isolating. These things happen just immediately. And if you do that, you can bring this under control.
Have you seen, well, I'm leading towards wrapping up. We're going to take about 45 minutes, so we have 5 minutes left. But, one question I'm getting from many members of our community, Brown community writ large, alumni, students, faculty, is they really want to do things to help. And people are trapped in their houses. And I think they're feeling kind of unable to do something that they feel is making a contribution. And maybe this is a hard question, but do you have any advice or suggestions on what people can do if they want to help people who are affected by this disease, help people who are unemployed, help healthcare providers who are really on the front lines?
Jim, I'll let you start this one off if you don't.
Well, I think, for example, we've never really had a massive scale up of a public health workforce in order to take on a pandemic. We're going to need one. And so, one of the things we're talking about is whether, laid off restaurant workers can become part of this workforce. That's what we're going to need. So I think there are going to be a number of real jobs, actually, and of course, need for volunteers to tackle this pandemic. I think that if citizens inform themselves and just ask very simple questions, has any country or locale been able to bring this under control? And if so, what did they do? And what do we need to do? As citizens, if they make it clear that and demand that you put these systems in place in every state, I think that's the most important thing that everyone can do. We need the democracy to work here in the sense that the will of the people has to be, very loud and very clear. And they kind of have to say to those of us who are public health practitioners, no excuses, guys. Don't tell me it's hard, it's complicated. Enough of that. Tell us what is needed, and then tell us what we can do to help make that happen.
Yep, good.
It's really hard to top that. I was just going to say, this is a moment where I think not enough public health leaders have been aggressive and bold enough in their vision for what is possible. And I actually find that when I'm talking to friends and family and colleagues outside of public health, they have a hunger and an appetite for being much more aggressive than what people in the public health community. And I think it's just, we sort of still have this mindset of people aren't going to be willing to do it. There aren't going to be enough resources. I think if there's ever a case to be made that we need to go big on public health, it is now, and it is now for the next 12, 18 months. And then to reset the entire conversation about where public health belongs on our national policy agenda, because we have seen the impact of not prioritizing public health in terms of how it affects every part of our society.
So thank you for that. And just final question. I think a lot of people also they're feeling, it's an incredibly stressful time. And, how can we be hopeful? Do you see any silver linings in this, that we're going to maybe live differently or live better as a result of having come through this?
So I see a lot of silver linings in how the next, again, I keep saying 12 to 18 months because I keep being very hopeful that in that time period, we will have a vaccine. There's a lot of hopefulness around therapies people are building. I think my hope is that this sort of shared experience creates more of a sense of community, which would be in some ways ironic because here we are distancing ourselves, but we're all going through this experience together. And my hope is that that changes things. On a political level, I've been feeling less of a partisan divide. I see a lot of liberals and conservatives, red states and blue states, realizing that, the virus doesn't discriminate based on whether you're a Republican or a Democrat. Great leadership from some GOP folks. My hope is it sort of reshuffles the incredible polarization that we've been feeling on the political front. And then, as Jim alluded to, as we emerge from this, I think it does allow us to have some very different conversations about how do we organize our society? What do we prioritize? How do we do globalization better than we've done it before? Globalization is still reality. So I think there's an opportunity to do a lot of things better as we emerge from this. But it won't happen naturally. It'll happen if we are very deliberate and focused on wanting to create a better world order.
Thank you. And Jim, did you want to conclude with anything?
Yeah, you know, I see a lot of great conversations happening. I see, you know, scientists trying to think about, you know, better ways of doing it. I was just on the phone today with businesses like Salesforce and Accenture who are trying to do everything they can to bring their tools to help us, you know, figure out a way to do this very complicated and logistically complex work. So there's a lot of coming together in parts of the world where they don't normally talk to each other, public health officials and folks from Salesforce and Accenture. I think though that the hopefulness will come when people can say, okay, now we're fighting back, right? This is what happened in Korea. They talk about it, you know, as I said, they talk about the virus almost as if it's a person with specific personality characteristics, with ways of avoiding them, and then they have ways of catching it. And we've got to get there where everyone in the United States feels like we're on offense. We can do this. And I think when that happens, and I hope that happens very, very soon, we're doing everything we can to try to get there. When that happens, I think you're going to see a coming together of American people. And I hope that it extends to the rest of the world that will be unique in our history. I mean, we've not had to do this before. I've seen this happen in other parts of the world. I've seen this, you know, the reason that China, Korea, Hong Kong, the reason they responded so quickly is they've been scared to death before. SARS scared the heck out of the entire, you know, it's not just Chinese people in China. It scared the heck out of the diaspora of Chinese people. It scared the heck out of the folks in Hong Kong. There was just so much drama around it in Hong Kong, especially. And in Korea, MERS, they had a MERS outbreak. And, you know, with a 30% death rate, it's not very infectious, but 30% death rate scared the heck out of the Koreans. And they ended up changing the laws so that in a pandemic like this, the laws change and they can access things that they can't normally access. So, you know, going through this and then fighting back, I think it will change the society, our society for the better. And I can't wait for it to start.
Me too. Well, look, just to conclude, I want to thank both of you for taking the time to talk to the Brown community today. I know both of you are incredibly busy, and I want to thank you for the work you're doing to help us take the offense and beat back this pandemic. Thank you.
Thank you, Chris.
Bye.
Thanks, Chris. Bye-bye.